because the topic is a little bit sensitive to a lot of people. You know, I'm a hospice nurse, and so I'm working daily with people who are dying. I'm not helping people to die, I'm helping people who are dying. And that's a big difference, you guys, so think about that. But I'm sure that if I ask the question, would you like to just die in your sleep? Most of us, I know me, I know I would say, yes, I hope that I just go to sleep one night and I die. You know, I don't want to have a long disease. I don't want to have a long illness. I don't want to be dependent or any of the stuff that goes along with that. I just hope I live and then, you know, I die one night. And I think that's about how really almost everybody feels. So the way to die in your sleep is to have the people that love you know that that's what you want. And that means that you have a frank discussion with your spouse or your children, or actually better to do it with both, to everybody, because after the fact, the family is often left discussing and arguing amongst themselves about, you know, who made the decision to let mom or dad die without intervention. Because the point of the intervention with the elderly, you guys, and I see it all the time, and the people I work with, we see it all the time, is somebody that's much older has a fall or has a cardiac event or something significant where they may have 40 years ago just gone ahead and passed away peacefully. But in our day and age where living at all costs seems to be the ticket that we're selling, that person gets escorted to the emergency room for emergency procedures, whatnot, many times ending up with a surgery that they don't really recover from well, and ending up in the ICU, intubated, then extubated, and then maybe they go to rehab for 6 weeks, maybe another 6 weeks, and ultimately end up with me. It's just like they've been poked and prodded and procedures done until there's just like nothing else we can do. And then they come to me. And many times that all was for naught, because the end result is the same. The person is going to die. When you go to the emergency room, or you go, if you have a catastrophic event and you're older and you go to the ER, you know, what you get sold is, I'm going to do this procedure for you, and if it's a heart seizure, it's a cardiologist. If it's, you know, a brain injury, it'd be a neurologist. If it's a fall, it's an orthopedic specialist, whatever. They're going to look at their particular specialty, and they're going to say, I can fix that. And they can fix that many times. But what they're not looking at is the whole picture. Because we are not just made up of one part. We're made of many parts, and they all work together. And when you have an insult or an injury to one area, there's a rippling effect through your body for the other areas. And what we have to look at is, what is the picture going to be like after I have this intervention? Because what people hear, families and patients hear, is, I'm going to go back to my way of life that I was prior to this event. But in reality, most of the time, it's the beginning of a long and slow decline. The kind of decline that, you know, you don't want, I don't want, and they probably don't want either. And what I mean by that is a decline of dependency, finances being used up, rehab that really doesn't get them anywhere, and just a long, slow dying. What we're not giving them is a living period. We're giving them a longer dying period. And it's something that, you know, we have to come to grips with, because life is a circle. And when we're born and we're going to die, we're all going to die. And we have to get over our fear of it and stop thinking of, you know, I have to live no matter what. I have to live at all costs, because there is an art and a gift of dying well. And we need to learn more about that in our society. So it's kind of something that families often say, if I knew now what I knew then, I wouldn't have opted for this procedure. But it sounded like my dad was going to get better and I was going to have him back the way he was. And, you know, that's just not usually the reality. So if that makes sense to you, then I really, really want to stress to you to talk to your parents, if you still have your parents with you, or your grandparents. Talk to them and find out what they want. You know, ask them, what does dying well mean to you? and see what it does mean to them. And that way, when it comes to that point, you can help that happen for them. And if that means dying in the home, then you're not going to intervene and send them to the emergency room when they have a heart attack, or when they're very, very ill, you're going to get them on hospice so that we can come in and help with symptom management, etc. It also means, very important, that they're going to have something called a do not resuscitate, a DNR. And all that means is, if your heart stops, I'm not going to restart it. If you stop breathing, I'm not going to intubate you and get your respirations going artificially. That's all a DNR is. And if your family member says, I'd really rather just die quietly in my home, then you got to have a DNR. And it's a yellow piece of paper. Go get it filled out. Go to the medical doctor's visit with your grandpa or your mom or dad, and get this paper signed and get it on your refrigerator, and just have the frank discussion. Don't be afraid of it. Like I said, it's the circle of life. We're born and we die, and it's the way it is. And the less stigma it has, and the less fear we have about it, the more we can control how it's going to go, and we can actually embrace it. And to be honest, I find helping people as they're going through that process such a tender, spiritual, emotional event, just like when I was a labor and delivery nurse and bringing those little souls into the world. This is a transition of those souls out of this world into wherever the next place is. So point being, have the conversation. Don't be afraid of it. And I hope it wasn't uncomfortable for anybody. All right.